Hi, and welcome to the Healthy Living series. I'm Angelica Ladd, Community Relations Specialist here at Dartmouth Hitchcock Health. And this evening we are joined by Dr. George Thomas to better understand epilepsy. But first, we have a few housekeeping items that I would like to go through with you. If you would like to ask a question, please use the question and answer function. We should have plenty of time for questions at the end of the presentation. Tonight's event is being recorded and will be posted on our Healthy Living series webpage at go.dh.org/HLS, as well as YouTube. So you can watch it again or you can share it with family, friends. We also have closed captioning available this evening. So if you just click on that closed caption icon, you should have live captioning there for your needs. And then at the end of the event, if you will be sent a 3-minute survey. We would be really grateful if you could fill out that survey, as that helps us to plan programming for future events. And then finally, on December 8th, we are hosting a Healthy Living series on supporting a loved one in a mental health crisis. If you'd like to register, you can also do that at go.dh.org/HLS. So very important and timely subject matter. So now we can get things started. Again, we're joined tonight by Dr. George Thomas, and his work at DHMC focuses on patients with a variety of seizure disorders. He also serves as the Director of Critical Care Electroencephalography, EEG. He has practiced at DHMC since 2011 and earned his MD and PhD degrees at the University of Kansas Medical Scientist Training Program. Outside of his work, he enjoys antique airplanes and is a member of the Experimental Aircraft Association. So thank you, Dr. Thomas, for being with us tonight. And we are going to kick things off. I'm going to share the slides for you.
All right.
You're all set.
Okay. Oh, there we go. Perfect. All right. I'd like to thank Angelica for having me here. Really appreciate the opportunity. November is Epilepsy Awareness Month, so it's a great talk about this. And I put this talk together mostly. It's just a lot of things that I try and tell people about epilepsy and seizure disorders. There's a lot of things that people don't realize and people don't know, and also a lot of things that we're learning. So I hope that this is helpful. It's not advancing. Did you do that or did I? Uh-oh.
I can't tell if that was me or you. Hold on.
Okay.
Let's try this again.
Okay.
Sorry. Let's see. So we'll share it. There you go. So you should be able to.
All right, there, and then. Okay, now it's working perfect. Thank you.
Perfect. Good.
So I'll start off with a question that you can answer yourself, just to yourself rather. And now it's going forward. You have to go back. Okay, we'll try this one more time. All right, so here's the question. Do you know someone with epilepsy? The most of you will probably say, no, I've never really met anybody with epilepsy, but I'm going to show you how that's probably actually not true, because epilepsy is more common than is generally recognized. So I guess to start off with, we should talk about, what exactly is epilepsy. The International League Against Epilepsy, the ILAE, they define epilepsy as a condition characterized by at least 2 unprovoked seizures more than 24 hours apart. So Somebody can have one seizure. In fact, about 10% of the population have one seizure in their lifetime, but that's not the same thing as epilepsy. About 1.5% of the population has recurrent unprovoked seizures epilepsy. So that means 1 out of every 65 people that you see in a day has a seizure disorder. And I've seen more than 65 people just walking to the hospital today. And I'm sure a lot of us have just in the course of our normal activities. But the term epilepsy it's a very broad term. It's not a single disease. It's a very general term that includes a lot of very specific conditions. And it's sort of like headaches. Headaches are a really common condition, and we all know people who have headaches, and some people have tension headaches, some people have migraine headaches, and there's other less common things like trigeminal neuralgia that are more specific diagnoses under the kind of broad umbrella term of headaches. And all of these, unique conditions have specific treatment. So it's important to understand what the real specific diagnosis is. And this is a diagram that, again, comes from the International League Against Epilepsy, and just showing that there are different seizure types. So we talk about, seizures that start at what we call those focal seizures, and then some seizures start everywhere at once. Those are generalized, and then sometimes we don't know. So those are seizure types. Then there are epilepsy types. These are the specific kinds of recurrent seizure disorders. They can be focal or generalized or both, or sometimes we don't know. And there's a whole list of potential causes for seizures. They can be structural, which means some sort of abnormality on MRI, for example. It could be an old like stroke that leaves a little bit of scar tissue. There are genetic causes for seizures. Some infections cause seizures. In fact, worldwide, the most common cause for epilepsy is actually infectious. It's not so much in the United States here, but in worldwide it is. There's a whole other things in this list of causes for a seizure disorder. And sometimes we can characterize the whole picture into an epilepsy syndrome. Some of these are one of them is called Dravet syndrome. I'm going to a little comment about that later. And Lennox-Gastaut syndrome is another epilepsy syndrome. There are a lot of them, but oftentimes seizures don't really go to one of these syndromic sort of patterns. So just to give you an idea that when you say the word epilepsy, it really doesn't quite capture all the little nuances of the disorder in an individual. So it's very confusing. If anybody is trying to sort through all the different terminology and phraseology and classes of seizures and seizure disorders, it's really confusing. I'm sort of like to think it's because we're getting better. We're understanding seizure disorders better and better every year. Our treatments are becoming better. The classifications that were used in the past just weren't detailed enough to really do the seizure, really describe the seizure disorder in enough detail to be very helpful. So in the past, like when I was a child, I remember the term grand mal and petit mal as types of epilepsy, and these terms, grand mal I think generally means a generalized convulsion, and petit mal are sort of smaller seizures, maybe staring spells. And while these terms are outdated, they're still in use, and they still have some value in describing, seizure types, and when you're communicating from one person to another, what is actually happening. But part of the problem is the terminology is redundant and a little bit vague. Just for an example, and I won't go into too much detail with it, but generalized seizures and generalized epilepsy, even though they sound an awful lot alike, and they do overlap quite a bit in some people, they're not necessarily the same thing. So if you've looked at the terminology to try and understand seizure disorders better and been confused, discouraged, it's just an unfortunate fact right now that the terminology is dynamic and it is sometimes hard to understand. There are a lot of tests that are involved with the diagnosis and treatment of epilepsy. One of the most common is an MRI. The reason we do MRIs is to look for basically structural abnormalities that can cause seizures. As I mentioned before, strokes are a common cause of late onset seizures in adults. Infections sometimes can be the source of seizures. Sometimes birth abnormalities that cause electrical malfunctions, cortical abnormalities can cause seizures, and all those things can often be seen on MRI. So that helps explain why somebody's having seizures. EEG is another really common test that we do, and it looks for electrical changes that are associated with seizures. So there's certain electrical changes that we can see on EEG that we know are associated with seizures. But none of these tests, the MRI or the EEG, are really definitive, and they're not required to, you don't have to have an abnormal MRI or an abnormal EEG to have a diagnosis of epilepsy. They just sort of help us understand the nature of what the disorder is. We have an epilepsy monitoring unit, or an EMU, here at Dartmouth, and this is a special area of the hospital that's designed specifically to be a safe environment to study seizures or seizure-like symptoms. We use this when we're not really sure exactly what a patient might be experiencing at home. So often in clinic, we talk to people and they describe some sort of transient event. And sometimes it's really clear what the person. Nowadays, a lot of people carry cell phones with them that have cameras on them, and so we have the advantage of that, and we can see sort of firsthand, what's going on. But oftentimes it's not clear, even if somebody does have like video from a cell phone. And to put a finer point on it, we bring people into our epilepsy monitoring unit and actually try and provoke the symptoms that they're having at home so that we understand them better. And sometimes we find they are in fact seizures. And other times we find out that they're not seizures at all. They're something entirely different. The aim of all this is to help us understand what's the best treatment. Sometimes the testing can suggest a specific medication that might be most helpful, and other times there are non-pharmacological treatments that are helpful. Now, there are also a lot of different epilepsy medications, or anticonvulsants, they used to be called. And all of them are probably about as effective as the next in terms of treating seizures. So it's not really, one that's the best, if you will, of all of them. They all are effective, but they all have wildly different side effects, and that's often what we use to decide which is the best for a particular patient. I here that are common, and you may have heard of them before. Depakote is a great anti-seizure medicine, works wonderfully. It has a couple of interesting side effects. It's very mood stabilizing. So in people that happen to have mood disorders as well, Depakote can sometimes help that part of their care as well. Depakote can also cause weight gain. So in some people that would be something you would not want to do. In other people, it's okay. Keppra is another anti-seizure medicine. It works great. In contrast to Depakote, and it's can actually aggravate mood problems. So in somebody who has a pre-existing mood problem, like depression, for example, Keppra certainly can be useful, but it might not be the first choice because it could actually aggravate the underlying mood condition. Lamictal is another great anti-seizure medicine. And just like Depakote, it's very mood stabilizing. It's usually very well tolerated, so you can use those two in the same kind of patient and help them overall. Topamax is another very broad spectrum anti-seizure medicine, and it has a couple of interesting side effects. It has sometimes can have a negative effect on memory, and in some people, if they have a pre-existing memory problem, you would try and avoid that medicine. But actually, a really good headache preventative medicine. So a lot of people without seizure disorders take Topamax to keep their under control. And in a patient with seizures who also has migraine headaches, for example, this is potentially a great choice. And Tegretol is another seizure medicine, and it has it's the drug of choice to treat a condition called trigeminal neuralgia. not related to seizures. But if somebody happens to have trigeminal neuralgia as well as seizures, those are some examples of great seizure medicines. There's not one of them that's superior to the other in terms of controlling seizures, but they all have wildly different side effects, and sometimes those can be used to somebody's advantage. Seizure medicines control seizures in about 3/4 of patients. So most people that have seizures reasonable control with medications alone. And that's pretty good. That means if somebody develops a seizure disorder, they're able, if they take the medicines as they're prescribed, they can work, they can usually drive, and lead otherwise productive lives and go about their life like they'd like to. A minority of people with seizures have medically refractory epilepsy. I've got a couple comments about that a little bit later, but most people, seizures are sufficient. Their medicines rather are sufficient to control their seizures. But I think it's important to remember that epilepsy is just not about seizures. So seizures generally are sort of relatively rare, meaning they happen, varies from person to person, of course, but sometimes every few years, sometimes every few weeks, but relatively rare outward evidence of underlying brain dysfunction. And so even between seizures, there are a lot of symptoms that patients with seizure disorders complain of. Depression is really very common. Thinking problems, cognitive impairment, memory problems. 40% of people have memory problems. The suicide rate of patients with seizure disorders is twice that of the general population. They also have a decreased life expectancy by 18 years compared to the general population. So even in patients who have well-controlled seizures, there's still underlying brain dysfunction that can really impact their quality of life. Now, this is a little cartoon that I made a few years ago, and just shows how what different things can affect quality of life in patients with seizures. So QOLs, this is shorthand for quality of life. And I already mentioned some of this. Depression, if you're depressed, your quality of life goes down. If you have memory problems, quality of life can be affected. There's still, even at this date, some stigma associated with this diagnosis. As I mentioned, 1 in 65 people that you meet have a seizure disorder, but I'm pretty sure that they don't necessarily advertise it. So there's still a lot of stigma associated with this condition. Social isolation, in part because of the stigma and in part maybe because of depression, can affect quality of life. And the reproductive issues. Many women with seizure disorders are under the wrong impression that if they're taking seizure medicines, they can't have children, and that's not true. Most women with seizure disorders who take anti-seizure medicines have perfectly normal children. As I mentioned, suicide. The lack of independence is a really significant factor that affects your quality of life, and it's also something that a lot of people with epilepsy deal with. Poor self-esteem, medical costs. Some of these seizure medicines can be really expensive. Any medicine is, usually an out-of-pocket expense, and some of them can be really outrageous, unfortunately. Missed days from work lead to underemployment, and so that can affect one's quality of life. And then the medicines themselves, some of them make you feel crummy, and often that's an individual effect. How it affects one person may be different than the next person, but we've all, I think, probably taken medicines that made us not feel 100% or like we're our best. And so all of these things can affect quality of life in patients with epilepsy. To confound that, a lot of these things are interrelated. For example, lack of independence contributes to poor self-esteem. And poor self-esteem might affect your compliance with medicines, your adherence to medicines that they're prescribed. Depression, we know, affects memory performance and cognitive performance. So you can see how everything is really interrelated, and they all have a huge impact on quality of life with seizures. So it's really a very complex disease. And just to pick on one one part of this, depression. Depression is not trivial at all. It's a common symptom in the general population. It's more common in patients with epilepsy. And it actually has some predictive value in terms of quality of life, QOL, which is not a surprise. We just saw the little diagram I made. But people who are depressed, often they don't respond to their medicines as well as somebody who's not depressed. And they also, some of our patients have seizures that aren't controlled with medicines, and they have epilepsy surgery, and they actually do worse in terms of seizure control than people with no depression. So depression is really a significant factor in determining quality of life, and also just how people respond to treatment. And despite the fact that it's really common in the population and more common in patients with epilepsy, it's grossly underrecognized, and that's honestly lack of training on the part of neurologists. We're trying to do better, but it's not something that for a long time was really emphasized. And patients tend to underreport it as well. It's really common, not just in patients with epilepsy, but in the general population. People don't like to say that they're depressed. I want to just take a moment to mention something while we're talking about quality of life. And this is kind of an uncomfortable subject, but there's this condition, and this is an acronym, SUDEP, SUDEP. It stands for sudden unexplained death in epilepsy. And the name is pretty descriptive. So the true incidence of this is really not known. We think maybe 1 in 1,000 patients with epilepsy die for reasons that we don't completely understand. Sometimes they stop breathing. Sometimes their heart stops beating properly. It's not always the consequence of a seizure. Only about a third of them appear to have had a seizure, but that's not really it's not really clear. It just emphasizes the importance of making sure that somebody with a suspected seizure diagnosis gets diagnosed and they get treated. So that's something that I think is really important to keep in mind, that epilepsy is a serious and potentially life-threatening condition. So there are a lot of lifestyle modifications that can really improve the quality of life of patients with epilepsy. I don't know where I heard this saying, the best medication is the one the patient will take, but it's really true. And it's not just doesn't just pertain to seizure medicines, but it doesn't do any good to prescribe a medication to a patient and they can't take it for whatever reason. Either side effects from it are horrible, or maybe it's just financially impossible to take that particular medicine. But incorporating medicines in a daily routine and compliant and adherent to everything, and that is hard to do sometimes, but that's important. Poor sleep is actually a pretty strong trigger for seizures in some people. I always encourage patients with seizures to make sure they get enough sleep. And like I said, it's rather individual, but in some people, they might stay up late studying for a test or something like that, and that consistently makes them have a seizure. And some people have very specific triggers too, some of them are easy to maybe suspect. For example, flashing lights. Some women exhibit a pattern of their seizures getting worse about the time that they have their menstrual cycles. This is actually the most common trigger for seizures that patients report. So controlling stress is always something really important to emphasize as well. Then there are a lot of non-drug treatments or non-traditional drug treatments for epilepsy that are worth talking about too. Some of you may have heard about a ketogenic diet, epilepsy surgery, and there are various forms of nerve stimulation, neuronal stimulation that can be used. One of the vagus nerve stimulator. This has been around for quite a while. There's a relatively newer device called a responsive neurostimulator, or a NeuroPace is the brand name of it. More recently, deep brain stimulation. Sometimes hormonal regulation in the form of oral contraceptives that are progesterone-based as opposed to estrogen-based. And then at think a lot of us have heard about cannabis as a treatment for not only epilepsy, but a lot of things. So the ketogenic diet, it depends on who you talk to when you say ketogenic diet, what kind of depression you're generating. So there's a classic ketogenic diet. This is usually a very high-fat, zero-carbohydrate diet that's given by a feeding tube. It's nothing that most people will be able to tolerate, but it's really can induce a condition called ketosis. So it's just a metabolic change, and that in some patients can reduce seizures. But this is not something that usually requires a feeding tube. It's not anything that would be palatable. You couldn't eat this diet in any conventional way. But when most people, when they talk about a ketogenic diet, they're talking about a modified Atkins diet, which is, again, high fat and protein and low carb diet, not no carb. So this is, bacon and meat kind of diet. And it's easily managed by most people. A lot of people have adopted this sort of diet for weight loss and other reasons, and it's pretty easy to do. And it might, in some people, give a little edge to their seizure control. It's not anything I think would be useful as the sole treatment for a seizure disorder, but it's something that a lot of people find helps enough that it's worth doing. As I mentioned, brain stimulation is something that an option that we have had for a long time in the form of a VNS, vagus stimulator, and some other recent developments. The vagus nerve stimulator, the vagus nerve is a nerve in our neck, and there's simply a little stimulating wire that's wrapped around it, and a little stimulation is delivered to the nerve, and it goes sort of up and into the brain. And that is probably about as effective as a conventional anti-seizure medicine, but without the typical side effects of it. The RNS, or NeuroPace device, this is newer. This is implanted directly in the brain, and it is a little more involved, but it can also change and reduce seizures. And more recently, we have something called a deep brain stimulator that's available, and this is actually it's a technique that was been available in Europe for decades, but only recently, I think a couple of years ago, was it approved by the FDA for use in the U.S. However, we've been using DBS for Parkinson's disease and other things for decades here in the U.S., and it's only recently been approved, I think, in Europe. So we know how to do this. It's just simply putting the leads in a different structure, and that too can be effective at controlling some kinds of seizures that don't respond to medications. And then I mentioned epilepsy surgery. Many people don't think of surgical treatments or therapies for a seizure disorder, but this has been available for a long time, and it can be very effective if we select the right patients. And essentially what it amounts to is just physically removing or surgically removing the source of the seizures when they start. It happens to be a little bit of scar tissue. Then often that's very helpful at controlling the seizures. This, of course, isn't anything that is done without a lot of thought as to where the seizures start, and then also what are the potential risks of the surgery. So there's a lot of testing involved to get to that point. And so one treatment that we have that might actually be able to cure epilepsy, and I say cure in contrast to everything else, which is a treatment. It doesn't really make the disease go away, but it's possible to actually cure epilepsy with epilepsy surgery. And then cannabis. I think we've all probably heard a lot of news about cannabis, the health effects or health benefits of cannabis, not just for epilepsy, but for a lot of things. And we really are just starting to learn about this. We think of there being two main parts to cannabis: CBD oil versus the THC component of it. And what I think I know about this is that CBD oil seems to be effective for a couple of specific conditions. One of them in particular is called Dravet syndrome. This is a childhood epilepsy that's generally not responsive to conventional anticonvulsants, but shows a pretty robust response to CBD oil. And that, of course, is generated some interest in cannabis in general, treating seizure disorders in general. And there's not a lot of research yet to really make any really strong recommendations. There's actually some evidence that THC might make some seizure disorders worse. So it's really hard to tell, when somebody says, I'm having seizures, do you think cannabis will help? I'm not sure that there's a clear answer to that. All that being said, a lot of patients do find it helpful or worthwhile to use cannabis. Some things to watch out for is the dosing of this is not really clear. When I prescribe something like Depakote, I have a pretty good sense of how much to give somebody, or at least calculate it based on their weight, for example. And I also have a pretty reasonable understanding of how it might interact with other medications that they're on. And those things just have not been studied that well when it comes to cannabis products. And to confound that, the actual product that somebody has can be variable. It's an organic, it's a agricultural product, really. So the concentration of CBD and THC ratio between the two varies from species to species, and I suspect probably from month to month and year to year, just based on growing conditions. Many states, including New Hampshire and Vermont, have therapeutic cannabis for patients with a qualifying diagnosis, and epilepsy is one of those in both those states, and as far as I know, in most other states, if not all of them, they can have access to cannabis products. And over the few years that they've been, several years actually at this point, they've been open, a lot of people have signed up for it, and a lot of people have found that to be very helpful. And I have noticed that the people who run the therapeutic cannabis programs at dispensaries are a great source of information and support. Because as I said, I don't know what the proper dosing for some of these things are. So it's been a good relationship. And again, some people find that it's helpful, and it's very individual. So one of the things I mentioned earlier was, depression is a major factor when it comes to a lot of quality of life and outcomes in seizure disorders. And access to mental health is a challenge, not just in this part of the country. I'll talk about that in a second, but all over the place. It's estimated that 70% of people with mental illness go untreated. That's really, really unfortunate. A lot of it has to do with avoidance of discrimination and stigma associated with mental illness. It kind of skips over, but down at the bottom, depression. 56.3% of people with depression are untreated, and it's over half of people who could benefit from treatment avoid treatment because of discrimination and stigma. And then we live in a very rural area, and it's an acute issue in terms of mental health access. And part of that has to do with rural culture generally dissuading people from seeking help. I'm not from New England, I'm from Missouri. And I know that New Englanders are, sturdy people, and they don't like to ask for help, perhaps, just in general. Another really big problem is rural communities really lack any sort of privacy or anonymity. I live in a small town, and the news travels really, really fast. So in rural areas, this mental health issue is even more acutely felt. Oops. Here's what I thought of. Access to transportation and healthcare, utilization in the rural region. I forget where this was. It was North Carolina where this study was done. And what they found was that people who had a driver's license went to twice as many doctor's appointments, basically. I guess the flip side of that is people without a driver's license saw the doctor only half as much. So in this particular area, our area where we live right now, there really is no public transportation. Everybody's dependent on their personal vehicles for transportation. And that one factor can have a huge impact on how often and how you access the healthcare system. And that leads me into the next thing. So I think everybody can understand why patients with seizures are maybe at risk for having accidents, for example, harming themselves, harming others while they're driving. And some driving rules that have to be considered. So New Hampshire, the rules are that you can obtain a driver's license if you've been seizure-free for 12 months, sooner if a doctor says it's okay. Physicians are not required to report patients to the DMV, so I typically don't report patients to the DMV. This patient's got a seizure disorder. Usually we just talk about it. The 12-month duration is sort of an outlier in the region. The other states put a number of like 3 to 6 months on this, and this is kind of an outlier. All of the states, have this caveat that if a physician says it's okay to drive, then it's probably okay. Vermont's similar. You're eligible to get a driver's license after filling out some paperwork to the commissioner, and they're the ones that actually decide. And again, in Vermont, we're not required to report, nor do we ever really report anybody for having a seizure disorder. And it used to be 6 months was their time frame. Several years ago, they renewed that, and it just is basically if a doctor says it's okay for you to drive, they'll consider it, and ultimately it's up to the commissioner. So people often think that their doctors have the power to restore their driving privileges, and we can help support them if we think it's safe, but it's actually up to the DMV. So self-management for epilepsy, active involvement in care. I mean, sticking with your medications is really important. If somebody takes their medications inconsistently and they're having a lot of seizures, it's really difficult to try and control things. This is really important. This isn't so much of an issue with epilepsy directly or specifically, but healthcare in general, reliance on evidence-based treatment. A lot of questionable information on the internet that lead people to try things that either are not effective or sometimes harmful. So at least trying to avoid things that are unproven. As I mentioned, some healthy lifestyle factors that can reduce your risk of seizures: getting good sleep, controlling stress, perhaps diet. As I mentioned, the modified Atkins diet sometimes can be helpful. And then treatment of comorbid conditions. We said depression, just untreated depression can actually make your epilepsy worse. There are a lot of barriers to managing epilepsy. Already alluded to untreated mental illness. And it's confusing, particularly if you're new to the idea of the diagnosis of epilepsy. The terminology is hard to get around sometimes, and it's very confusing. There's still a stigma, as I mentioned, associated with epilepsy. You know a lot more people that have epilepsy than you realize. Transportation is a huge issue. People with epilepsy sometimes have trouble driving. They can't drive because they have uncontrolled seizures. And that further impacts their ability to access healthcare. Things that are helpful: stress reduction, education, and social support too. Oh, more about medication adherence. So it's a modifiable risk factor. It's estimated that about 30, maybe a little bit more % of adults are non-adherent to their medicines. They don't take them as prescribed. It's probably higher in like teenagers, adolescents. And while seizures are bad, nobody enjoys having a seizure at all, there are some downstream consequences like fractures, other injuries, car accidents. Seizures lead to increased emergency department visits and admissions to hospitals. So certainly something to be avoided. Some of the things that influence medication adherence: personal belief in the need for medication. This is something that I've seen on one too many occasions where somebody has a disorder, they take a medicine as prescribed, they don't have seizures. Well, they take it and they erroneously conclude that they no longer have the seizure disorder. it seems hard to believe that somebody could come to that conclusion. But it happens. I've seen it on more than one occasion. Concern about side effects. If you've ever looked at the effects of your medicines on the internet, you know exactly what I'm talking about here. There are common side effects. With the Depakote, for example, I mentioned the weight gain. It's common enough that it's worth mentioning to people. If you look at the list of side effects from not just anti-seizure medicines, practically anything, it just goes on and on and on with the list, and which is never ending list of things nobody would want to experience. And some of those are really, really rare, but they're common things. So people are worried about the side effects, and sometimes justifiably, and sometimes they're not common things. As I mentioned, depression, anxiety affect medication adherence. The memory problems associated with seizure disorders can make people forget to take medications, and then sometimes it's really complex when people are on multiple seizure medicines, or they're on medicines for other medical conditions, and taking a lot of pills, and it's sometimes hard to manage. So it's not easy taking medicines as prescribed. There are a lot of like online organizations and groups that offer great support for people with seizure disorders. People with seizure disorders often feel isolated and alone, like nobody else around them understands what they're going through. And so these are great resources. This is one of my favorites, the Purple Peace Foundation. They usually plan, I don't know if they're doing this with the COVID situation right now, but they have trips, where they go to Disney World, Disneyland, and things of that nature, so that kids with seizure disorders can meet other kids with seizure disorders and do things that other kids do. This is my cousin's daughter, Amanda. So this is I'll just type in, this is my cousin's website. So I'm kind of plugging her website for her. At Dartmouth, we have a couple of programs. One of them is Hopscotch. This is an acronym. You can see it's Home-Based Self-Management and Cognitive Training Changes Lives. This is a program that's been on here for, I think, as long as I've been here, maybe even a little bit longer. And it's a program that teaches people tools to help improve their memory and compensate for some of the memory problems with epilepsy. As I mentioned, that's one of the most common things that people complain about, and this allows people to kind of learn to work around it. It's been a very popular program here. This is another nationwide organization that we're associated with, the Managing Epilepsy Network, or MEW Network, MEW. And again, it's a support group basically, and this is multiple institutions across the country. All these resources are available to anybody. There are even a lot of applications for your phone that can help with self-management of seizure disorders. It's really helpful as a physician if I know how often accurately people are having seizures. Sometimes people will keep a notebook, and they have the date and the time and exactly what happened and what they did for it. And that's really helpful to see if there's been a change over time, or to see if there's a pattern that emerges that can help us understand why they're having seizures. Other patients don't keep such detailed records, and sometimes it's really frustrating to try and work through it. At the very least, most patients have an alarm. You can set an alarm, and there are even apps for medication, specific medication reminders. And some applications have specific information about epilepsy. And all of these things help physical activity, sleep, stress level, life events, time management, and social support are all things that can help improve quality of life in patients with epilepsy. And I think this is my last slide. We tend to look at epilepsy as a condition of these episodes of of seizures, separated by long periods of being essentially normal. And we know that's not really true. Epilepsy is a chronic illness, much like diabetes or COPD. and it affects a lot of aspects of patients' lives. It can lead to depression, memory problems, loss of independence, and all that just degrades people's quality of life. And it really takes more than just a neurologist to help manage epilepsy. It really takes a lot of people, mental health resources, sometimes legal resources, not just in regards to driving, but in regards to workplace issues, social services, trying to navigate a complex healthcare system with limited resources. A care manager is often very helpful. I calculated one time, if I see, typically if I see somebody every 3 months, that's 4 times a year for 30 minutes. It comes out to like 0.02% of the time throughout an entire year. So my face-to-face time with most patients is really not that much. All these other resources are very important as well. And just helping people empower themselves to control and manage this condition is really helpful, not only in managing the condition, but also in their quality of life and well-being. But there are still a lot of really substantial barriers that make this quite a challenge even today. It's getting better, but it's still not an easy condition to live with or to manage. So I believe that's it.
Hi there.
Hi.
Thank you so much for that great
Oh, my
overview.
pleasure. Thank you.
So we have a couple questions in our Q&A.
Okay.
So we'll get started on those. So we have one question about how should people go about treating depression and seizures? Like, what would be the first steps?
I think the first step is, recognizing it and seeking out help for it. I think that's great. There are medications to help with depression and mood. They typically work best in conjunction with some sort of talk therapy as well. The typical medicines that are used to treat depression, SSRIs, Prozac is kind of the archetypal one. I think it's the oldest one of all of them, and some of them are better than others, and some of them, Wellbutrin is that a lot of people are on. But we have to be careful with that one because it can lower one's seizure threshold. So, picking the specific medication sometimes is important, and having a good relationship with a mental health provider, it could be a psychiatrist, psychologist, counselor, just somebody that you connect with basically and have a consistent relationship with is really important. And again, we know that improves your quality of life. It improves your ability to kind of stay on track with your medications. Your ability to manage everything. So it's really, I think it's very important managing epilepsy.
Does gender matter when it comes to epilepsy? Like, do men get epilepsy more than women, or vice versa, or is it pretty evenly split?
That's a great question. So it's pretty evenly split, but sometimes it manifests a little bit differently. So I alluded earlier to some hormonal influences, and some women exhibit this pattern where their seizures are worse, about the time that they have their menstrual periods, their menstrual cycles, and that's a challenge in and of itself. And sometimes there's hormonal therapies that can be helpful. In particular, estrogen, for example, tends to lower one's seizure threshold, where progesterone seems to at least be neutral or maybe be a little protective against seizures. And so sometimes oral contraceptives that are progesterone based, or even like the Depo-Provera, the shot that people get, those can be very helpful in some people. So we know that we do see that seizures sometimes follow a cyclic pattern in men. But I don't understand why. I'm not sure anybody really does. We assume that men's hormonal profile is sort of flat. We don't go through, monthly changes in testosterone, for example, at least not to the degree that, the kinds of changes that women see. So those cyclic patterns in men are not very well understood. Most people with seizure disorders have some sort of um, frequency to their seizures, like it might be in women, for example, if it's every 4 weeks, then it's often tied to their menstrual cycle. In men, there's again, it's not so clear what's driving that. So sometimes there are some subtle differences between men and women. It's a great question.
And then late onset epilepsy, like is it typical? Is that typical for people to develop epilepsy later in life, or
So
has it always been latent in a person?
So if you look at the incidence of like new epilepsy diagnosis over like age, there's a lot of epilepsy diagnoses in childhood, and then it kind of drops off into adolescence. It becomes less and less common. So it's a little bit, it's not terribly uncommon for an infant or a child to be diagnosed with epilepsy. And as they get older, it becomes a little less common. But then later in life, like 60, 70, that curve actually starts to go up again. And the reasons for that are different. So the seizure disorders that happen in kids tend to be genetic. That's why they show up early on, because it's an inborn genetic trait. And in the older group, the adults, it's usually accumulated injuries that underlie the seizure. So it could be head traumas, playing sports, motorcycle accidents, car accidents, things like that. Strokes are a common cause of seizure disorders, and usually the seizure disorder, if it's going to happen, it's like 2 years after the stroke. So it's so the underlying etiology or mechanism is different. But yeah, it's actually not that uncommon for epilepsy to develop in adults, and it's usually one of those sorts of factors. Dementia is another probably underrecognized association with seizures, seizure disorders. So it's thought that maybe 10% of patients with Alzheimer's disease have very small, subtle seizures. They're not necessarily convulsions, but they nonetheless can cause a lot of problems with thinking and memory, and people who already have trouble with their thinking and memory.
And then I wanted to ask a little bit about the research on music therapy. Are you familiar with that? I think that was kind of like a big finding earlier this year.
Right. So I wish I could tell you more about it, but there's this idea, this Mozart effect, that certain Mozart pieces can basically reduce seizures, right? It seems kind of far out. But one of our researchers here, he actually kind of identified some changes in brain physiology by playing Mozart music that might affect, might affect seizures. So I think that he ended up a TV show in New Zealand. I mean, it really was like, really people really caught on to this. It was a really interesting story. So I don't know much more about it than that. I'm sorry I don't, but it's fascinating. That Mozart gets blamed for not blamed, but a lot of things get attributed to Mozart for not only was he a great composer, but seems to have been able to improve our lives in a lot of other ways too.
And we can link that study, I think, to our Healthy Living Theories page if anyone's interested in taking a look at that.
Yeah.
We do have another question about alpha wave therapy. Is that something that can help with seizures?
So alpha wave therapy, what I think I understand when you say that is using, tell me if I've got this wrong, maybe I'm misunderstanding what it is, but using either light or sound to induce alpha waves in one's EEG. And that's an interesting idea. So, if anybody's had EEG, that they flash the lights in your eyes. It's pretty typical. And it's a way to sort of check reactivity, normal reactivity of one's the part of the brain that's involved with vision. And I think something, although we usually don't see it on routine EEGs, auditory stimulation probably does the same thing. It's a little, the area of your brain is a little bit smaller and it's harder to see, if you will, on EEG. But I think the idea is that if you can induce good brain waves, it might suppress bad brain waves. If I think that's what I understand about that, and I'm not aware that it's ever been like studied extensively, and you know, in a manner where I'd say this is definitely worth doing. But I've known a couple of people who seem to feel like they benefit from it, and it certainly is low risk. You know, in terms of side effects, they're practically none. And you know, if somebody finds that it helps them, I certainly wouldn't argue with them about it.
Thank you. If I'll just give everyone kind of one more minute. I think that's all the questions that we went through.
Okay.
But if you have any final words on epilepsy, when people should seek treatment, and how they can reach out to.
Yeah, I think it's a, you know, a scary thing to have a seizure, and like I said, it's maybe 10% of people in the population at some point in their lifetime have a seizure. They never have another one. There's always you know, the fear or the concern that you know, maybe it'll happen again. Sometimes it's hard to predict, but I think it's important to find out and be as aggressive and proactive in treating it, and in fact finding out, you know, if it is, you have risk for further seizures, and if you are, you know, what to do about it, because it has a huge impact on your quality of life in so many different ways. And most of the time, seizure disorders are manageable with you know, medicines that are usually very well tolerated. So.
It's good to know. We did.
All right.
We just got one more question actually about
Okay.
EMU monitoring.
Sure.
Does that happen more than once?
Depends. So it's just like, it's like any test. If it provides an answer that leads to a solution, then you know, sometimes people just go through the testing one time. Other times, you know, there may be no clear answer, or maybe the answers we thought we got from it were not enough, and so sometimes people will come back in and go through the testing again. It all depends. Yeah. Great question. And sometimes people are there for a few days. Sometimes they're there for more than a few days. It's all very individualized. It's one of the things I really liked about what I like about epilepsy is that the treatment of epilepsy, rather, it's all very individualized, and everybody is so unique and so different.
Well, I just want to thank everyone for tuning in tonight. Thank you so much, Dr. Thomas, for being with us, for sharing your time and your knowledge. And I'm very grateful to have you with us. Thank you.
Well, thanks for inviting me. I really appreciate it.
You're welcome. And so this, like I said, this is being recorded, and we will have it posted on our YouTube page in the next couple of days, as well as on our Healthy Living Series webpage, which is go.dh.org/HLS. So thank you all for coming tonight. Have a great night. Be safe. Take care.
All right. Thank you. Bye-bye.